Hi all. So welcome to the third module of serious discussion. Today we try to cover heart failure, the important point with HFrEF, HFpEF, along with that rapid management of the heart failure, what you can expect from the patient, and how the long-term prognosis of the patients of heart failure is. Along with that, we'll also discuss the valvular heart disease. Okay, so in which we'll focus on the main valvular heart disease. Then we'll discuss about the aortic disease, for example, aortic dissection. Then in a nutshell, we'll cover the pericarditis. Okay. Before this, we'll also cover the arrhythmia. Actually, the arrhythmia is per se a hybrid topic, but like an emergence topic, but we'll try to cover the basic approach of arrhythmia, like how to identify the ECG and like when to refer the patient to the emergency considering the ECG. The basic ECG, we will just have that over the idea, okay, overview. So then, after that, pulmonary artery hypertension. So that's all. This whole thing we'll try to cover in the third lecture of serious. So let's start with the heart failure. So first of all, we'll have a case and then let's see how it goes. So we have a 72-year-old male with hypertension, diabetes, presents with dyspnea on exertion. Then orthopnea is there. That means the dyspnea or breathlessness while lying supine. Okay. Then bilateral leg swelling is there. BP is 140/18. ECG shows LVH. Echo reveals LVEF of 60%. So what is the most likely diagnosis? Now the patient is indeed in the heart failure, but the ejection fraction is more than 50%. Right? So that has to be a HFpEF. Okay, so this has to be HFpEF and ejection fraction is more than 50%. So that's the diagnosis. Signs of heart failure with normal EF suggest HFpEF is commonly seen in the elderly, even diabetics patients and hypertensive patients. Okay, so let's see that. Now I'll just give you an over idea about what HFrEF and HFpEF are. So this is also the clinical patients will also present. So I'll just give you an over idea. Here people. Okay, so here we have the idea. Right. HFrEF and HFpEF. So as the name suggests, REF will have reduced ejection fraction that is less than 40%. And here ejection fraction will be more than 50%. Then what is between 40 to 50? That is heart failure with mid-range ejection fraction. Okay, mid-range ejection fraction. Why it is put in the mid-range is because this can worsen as HFrEF or can go into the HFpEF also. Okay, so that's why it is depending on the predisposing factor. For example, if patient is having aortic disease or patient is having hypertension, then there is a high propensity towards the HFpEF. And if patient is having ischemic heart disease, or if patient is having any structural heart disease in the form of, let's say, arrhythmia that's causing ischemic heart disease, or any coronary heart disease, or the patient is predisposed to these episodes, then there is an increased risk of HFrEF. Now, let's see what do we have in this. So, obviously, reduced ejection fraction means pump failure will occur. Okay, so heart failure with reduced pumping ability, and here there is a preserved pumping ability. Now, ejection fraction is less than 40%, ejection fraction is more than 50%. Okay, so heart failure here is in the systolic phase, here it is in the diastolic phase, right? So basically pumping is the function of systole, right? When symptoms will be same for both of them, shortness of breath, fatigue, edema, cough. Similarly here also shortness of breath, fatigue, edema and cough. But the most importantly, the complications of HFrEF, which are pulmonary edema, are more common here, but not here. Okay, and here the left ventricular will fail to pump the enough blood. That's the underlying pathophysiology. Whereas here, left ventricle is too stiff to accumulate the blood in case of diastole. And because of that, the blood going into the system will also be low. Okay, so because of that, there is a symptoms such as shortness of breath, fatigue, edema of the symptoms. So I hope you understood the basics of the HFrEF, HFpEF. Same thing that's mentioned over here. So in case of HFrEF, ejection fraction less than 40%, HFpEF, that is preserved ejection fraction, your ejection fraction will be more than 50%. Causes, as I suggested, ischemia, structural like myocarditis, dilated cardiomyopathy. And here, in HFpEF, most more are the lifestyle causes like hypertension, diabetes, aging, obesity. Okay, all these are the causes in HFpEF. Now, demography can be mostly seen in the people of around 30 to 50 years. Okay, because of myocardial infarction. But here, because of the wear and tear effect or because of the degenerative capacity, it will be seen in elderly female females, then metabolic syndromes, okay, because of the obesity, right? Here, echo will show LV is dilated. Here, there will be left ventricular hypertrophy, right? It is dilated over here and it is hypertrophied. That's a very significant difference. Okay, so hypertrophy is because of the pressure increase and dilation is because of the volume increase. Because of the reduced pump action, there will be more volume acquisition. And because of that, there is a dilation of the ventricles. You know what happens if there is a dilation? So as we discussed in the hypertension module also, if there is a dilation, there will be shift of the apex pip, right, to the left side, down and out. Okay, whereas here there is no shift of apex pip. Okay, no shift of apex pip, right? I hope you got it. So the next is BNP and anti-proBNP. Anti-proBNP is just a precursor of the BNP. Okay, so BNP will be high in place of HFrEF, whereas here it will be mild to moderately high. Now, how the BNP is produced? So BNP will be produced whenever there is a stretch of the ventricles. Now, the function of the BNP is caused to cause the natriuresis. That basically will reduce the overload or the load on the ventricles, right? Now, there is one enzyme that is called as neprilysin. Okay, so that's basically pharmacology concept. I will just explain over here. Okay, so I will just explain just a second over here. So suppose this is your heart. Okay, right? This is your left ventricle. Whenever there's an increased stretch of the left ventricle, there will be increase in the BNP. Now, in this BNP will cause natriuresis. That means it has the beneficial effect in cases of heart failure, right? It basically reducing the load on the heart, and that's a natural phenomenon. But there's one enzyme that's called as neprilysin. Okay, that neprilysin breaks down this BNP. So what we will do in case we have to treat the your heart failure, so we'll just inhibit this neprilysin. Okay, so that will be inhibited by your sacubitril. Okay, so that will be inhibited by your sacubitril. That's why one drug that is called as ARNI, that is angiotensin receptor blocker and neprilysin inhibitor. And the examples are sacubitril, valsartan, that has shown significant benefit in case of mortality of heart failure patients. Okay, so it's a very good drug. Okay, it's popularly known as Vimeda. Okay, so that's about ARNI. We'll discuss that in the pharmacology also. But I hope you got the idea how BNP, ARNIs and all are related to each other. Now, ARNI acts on BNP definitely, right? Okay, so we used the anti-proBNP. Anti-proBNP is the precursor of the BNP, but ARNI will not affect the anti-proBNP. Therefore, if patient is already on the ARNI, then we should use anti-proBNP for diagnosis of the heart failure. Okay, that's why if you see, like also BNP can be high in case of CKD, also in case of sepsis. Okay, and obviously it's high in heart failure. Okay, both have reduced and as well as preservation fraction. Sorry for this. Okay, so that will be high in CKD, sepsis, heart failure with reduced ejection fraction and preservation fraction. Therefore, we have to check for the anti-proBNP in the patients like this. Okay, also in ARNI it will be false to low. Okay, so we have to check anti-proBNP in these conditions, right? So response to treatment, HFrEF will show good response to the guideline-based therapy, and HFpEF has the limited benefit. But recently we have found in 2 studies that HFpEF has also shown significant effect with the help of your ARNIs as well as with the help of SGLT2 inhibitors. And we have also undergoing several studies. There are several studies undergoing for case of GLP-1 receptor. Okay, GLP-1 receptor inhibitors, right? For example, here semaglutide. Okay, uptake. Okay, that's about the heart failure. Now let's see the symptoms overall. What are the symptoms of heart failure? So for the classification of the patient into heart failure, we have the Framingham criteria. Okay, with the help of that, if patient is having paroxysmal nocturnal dyspnea, you know what is this, right? Whenever patient has to wake up from the sleep at the night time and he has to hang his legs from the bed, or he has to go to the window where he will take the fresh air and will feel good. That's here PNT occurs because of the air, however. Okay, so that's a very, very important and specific symptom for the heart failure. Then neck vein distension. it has to be seen in case of LV in reduced friction fractions. Then heart failure with reduced friction fractions. Then RAAS, that is vessel crepitation, can occur because of the volume movement. Cardiomegaly, again because of the ventricular enlargement. Acute pulmonary edema, again because of the HFrEF. S3 gallop can occur in case of increase in the ventricular volume. That's your S3 gallop. Okay, S3 occurs because of the ventricular rush, and S4 occurs because of the atrial launch. Okay, then CVP is more than 16 mmHg of water. That means high pressures of central venous pressure in case of heart failure. So it's very typically for all the features of heart failure. Now, minor criteria, which can also be seen in the heart failure, are ankle edema, night curve, dyspnea on exertion, hepatomegaly because of the congestive hepatitis or congestive hepatomegaly because of the right heart failure, fluid diffusion, tachycardia, weight loss. Okay, so I will just tell you mechanism on how congestive hepatomegaly can occur in case of heart failure. So till now we know this is how the heart is. Okay, this is your left ventricle, this is your right ventricle. Okay, so I'll just go all right, left ventricle is bigger. Okay, yeah. And this is your right atrium. This is your left atrium. So what happens whenever there's a pumping is not properly over here? So LV EDP, that is LV end diastolic pressure, will increase. Therefore, your left sided pulmonary vein, here pulmonary vein goes into the left atrium, right? So pulmonary capillary waist pressure also increases. Okay, so because of this pulmonary capillary waist pressure increase, so here we have lungs, right? So because of this increase in the pulmonary capillary waist pressure, there is a interstitial edema. Okay, interstitial edema because of the increase in the pressures, obviously. Because of that, there will be not proper filtration and the fluid will accumulate in the lung that gives the formation of the pulmonary edema. If it isn't like severe amount, okay, but if it's just few amount, then we say basal wells are there or basal crackles are there, right? Now, because of the increase in the fluid in the lung itself, the right-sided pulmonary artery pressure also increases, giving rise to pulmonary hypertension. Now, because of this pulmonary hypertension, there is again increase in the RVEDP, right ventricular end diastolic pressure. Because of this, again, right atrial pressure will increase. So that gives rise to right heart failure. And we know now the right heart failure, in case of right atrium, we have SVC and IVC. Okay, so SVC, the blood comes from the superior or upper extremity. In case of IVC, blood comes from the inferior part of the body. Now, in case of IVC, very important organ is liver, okay, which drains into the IVC with the help of hepatic veins. Now, whenever there is an increase in the pressure of the IVC or in the echo, you say IVC, it's non-collapsible. Okay, non-collapsible. Okay, normally it should be 4 to 6. If it's not that much or if it's bigger than that, then you say IVC are non-collapsible. That means IVC are overloaded the fluid. Okay, and that's when your hepatic venous pressure will increase and backflow pressure to the liver will increase, giving rise to hepatomegaly. Okay, so I hope you understood how the cycle or how things are attached to each other. Okay, that's why you see hepatomegaly. Now, here, as the IVC pressure are also increase, there will be increase in the fluid in case of periphery also, causing pedal edema. Okay, so that's why you can see pedal edema can occur in case of moreover in the right heart failure. Okay, also initially it used to call that as a congestive hepatitis or congestive heart failure. Okay, causing congestive hepatomegaly. In these patients, typically because of this hepatomegaly, there will be ischemic damage to the liver. Okay, so that's called as ischemic hepatitis also. So LFTs can also rise in this patient. But as and when you do the decongestion with the help of diuretics, the patient's liver function tests get back to the normal ones. Okay, so I hope you understood the complication and how we discuss the important aspects of the symptoms. Okay, so here, now let's see. We already discussed HFrEF, HFpEF in detail. Okay, so here is the summary of the BNP, NT-proBNP. Okay, so as we discussed, NT-proBNP is preferred in elderly, CKD, also in patients of RNI. Okay, and DNP can be easily available. That's why it's more of preferred. Okay, so BNP and NT-proBNP. So cutoff for the acute setting is more than 100, and for NT-proBNP, it's more than 300. Okay, so here are some pearls. If patient has these features, that is orthopnea, PND. Orthopnea means dyspnea while lying down. Okay, PND means dyspnea, and due to the increase in the sympathetic overactivity after patient enters into the REM sleep cycle or REM stage 2. Okay, in sleep, there is increase in the heart. There is increase in the heart is already under the load. Okay, LVF is not proper there, so there will be increase in the fluids in the lungs. Okay, I'm just simplifying it for you. Okay, and because of this, patient get breathlessness at night and air hunger at night. Okay, at night. Now, at this point, what body tries to do is to pull the blood into the periphery. Okay, and because of that, you have to wake up. Okay, so when you wake up or stand or go to the window, the blood is pulled to the periphery, goes to the periphery, and there is a decrease in the preload of the heart. Okay, I hope you understood this mechanism. That's why PND patient will have breathlessness in case of night when he sleeps after 2-3 hours. Okay, so PND is very closely mimicked to the other or PND mimics that specifically called as. That means some diseases can mimic like PND in case of heart failure. So what are those? First is called as asthma. Okay, so asthma is a close PND mimic, but in asthma there will be a wheeze, rhonchi will be there, and it's mostly seen as a early morning feature. Whereas in PND we saw it occurs after 2 hours of sleep. Okay, now if patient has slept at maybe 2 a.m., then we don't know. Okay, but although sneezing and rhonchi gives a cue about the asthma, and asthma is kind of reversible. Okay, patient will feel better with the bronchodilators, and here patient will not feel better unless we give diuretics. Okay, now one more important point about the PND mimics. Okay, so PND mimics. One more important point is also called as post-nasal drip. Okay, post-nasal drip. So make sure it's basically a nasal drip that going into the lungs, and because of that you might have some symptoms. Okay, so for such patients you should advise ENT references and the correction. If patient has any DNS or anything, then it should be corrected. Okay, also the eating habits causing regurgitation should be taken care of. Okay, for example, high protein diet or heavy meals at night, high carbs diet, okay, all should be advised to reduce the patient. Okay, then also in case of most of the times you will see asthma, post-nasal drip are the common mimics. Also like ACOPD, okay, acute exacerbation of COPD, okay, acute exacerbation of bronchial asthma, we can see these symptoms. Okay, so here the probability of the heart failure increases whenever patient has an increase in the JVP. There is a S3 because of the ventricular overload or ventricular rush. Then basal crepitations are there, so it gives rise to the high probability of the HFrEF or heart failure in general. Then BNP is normal, then heart failure becomes very unlikely. Okay, because it has high negative predictive value. That means if it's not there, okay, that means if BNP is normal, that means very low chances that the patient is heart failure. Okay, HFpEF is often misdiagnosed as COPD asthma. Because patient has breathlessness and ejection fraction is normal, you right away start the bronchodilator. So don't make this mistake. SGLT2 inhibitors have shown very significant benefit in case of HFpEF. Also, management of the weight of the person, lifestyle changes, because we saw it's because of the obesity, hypertension. So management of the risk factors plays very important role in the HFpEF. We will see in the upcoming slide also about how to treat HFrEF and HFpEF. Then check pulse pressure. If it is narrow, it is mostly seen in the low output states. That's the pulse pressure. So that's the difference between systolic BP minus diastolic BP. So now let's see some echo features of HFrEF versus HFpEF. I know we have the basic idea already. HFrEF ejection fraction is less. HFpEF ejection fraction is more. LV size is dilated. Here it's small to normal, and there is LVH over here. Okay, in case of HFpEF. Now LA size is enlarged in these cases. because of the increase in the left ventricular and diastolic pressures. Here also it can be increased. Okay, diastolic function may be abnormal, and here impaired relaxation typically in case of diastole, and that called as EA reversal. Okay, that's called as EA reversal. So this is a very, very important feature of the diastolic heart failure. Earlier they used to say it as a diastolic heart failure, but now you can categorize the patient as HFpEF. Okay. Okay, so then PE ratio. So E ratio is also more than 15, is quite common in these cases. And here, if LV pressure is increased, LV filling pressure is increased, then only E ratio will be high. Okay, then talking about the TR-jet velocity. So TR-jet velocity can be elevated here, and here also it is more than 2.8. Okay, can show pulmonary hypertension. When RV dysfunction in advanced stages, you can see RV dysfunction and HFrEF, where also it can occur. Pericardial effusion, here you have to check for tamponade, here about the constriction, okay, very constrictive pericarditis. So HFpEF diagnosis is often based on the elevated BNP diastolic dysfunction and the clinical heart failure signs. It preserves different fractions. Now let's see how do we manage the heart failure on the OPD basis. Okay, so HFrEF, some drugs have shown proven mortality benefits. So let's see those. Okay, so first is it's based on the 4 pillars. So first is your ARNI. We have already discussed ARNI. Then your ACE inhibitors and ARBs. Okay, beta blockers. And also here the 4th one is SGLT2 inhibitors. And also recently tirzepatide has shown good benefit on the heart failure. Okay, so these are the important drugs or important 4 pillars. So first will be 1, then 2nd, then 3rd, then beta blocker was earlier 4th. Now I would say GLP will replace it somewhat. Okay, so preferred over ACEi inhibitors if tolerated well. Your sacropetrial valsartan or your RNA. I already told angiotensin receptor and neprilysin inhibitor. I'll just tell you the mechanism about the heart failure. Suppose this is the heart failure. This is heart. Okay. So suppose heart is not able to pump enough blood. So that's a heart failure. So what happens in heart failure? Normally 3 systems gets activated. So what are those? First is your RAAS system will get activated. What is the function of the RAAS system? Normally the function of the RAAS system is for the salt and water retention. Okay, salt and water retention. Then your heart failure will activate the sympathetic nervous system. Okay, that will increase the heart rate. Okay, that will increase the contractility of the heart to tackle the failure. Okay, to tackle the heart failure because pumping is affected, right? And the 3rd is natriuresis system, or I will just write as the natriuretic peptides, either BNP or ANP. Okay, BNP is mostly by the ventricles, ANP is mostly by the arteries. Okay, so natriuretic peptides, and we know it is inhibited by what? It is inhibited by neprilysin. We just saw that, okay, when we were discussing about the BNP. And now, so neprilysin is basically inhibited. This is good system. Okay, so we have to inhibit this. Okay, these are bad system. Okay, so initially it might be good, but for a longer run it can be bad. That's why we inhibit this. Okay, and here we are inhibiting neprilysin, which is actually inhibiting the natriuretic peptide, and instead it is a good system because that is causing natriuresis. Okay, natriuresis means excretion of salt and water. Okay, salt and water. And because of that, there will be increase of the sodium. Okay, so what is the example for this? So for example, we have your sacubitril. Sacubitril. So this is a very, very important chart, and based on this, actually the entire treatment of the heart failure is revolving around. So RAAS inhibitors in the form of ARNI, ACE inhibitors, ARBs, right? Then sympathetic nervous system inhibitors in the form of your beta blockers, right? And then neprilysin inhibitors in the form of your sacubitril. Okay, so all of them have to be shown very good benefit. And recent times, there is one more, that is SGLT2. So SGLT2 is present in the proximal tubule of the kidneys. So it will cause excretion of water. excretion of the water plus some solute in the form of glucose. Okay, so because of this, there is a decrease in the preload and decrease in the symptoms of the heart failure also. And it has also shown mortality benefit. Okay, so I would say these are few things that you will have to remember when we talk about the heart failure. Now let's see. The first is your sacubitril valsartan. It has angiotensin receptor blocker as well as it has your sacubitril, that's your neprilysin inhibitor. So what is the dose for that? So and remember, whenever we give ACE inhibitors or ARBs or RNAs, we should consider the kidney functions. Your EGFR should be more than 30. Okay, that's a very important point. Okay, because it affects the kidney function. So that's the only point. Rest of the things, it's okay. Okay, so now here we go. Sacubitril valsartan. You can start at 50 mg. Should go from like low dose to high dose, and we can give up to 150 mg or up to 200 mg we can. Okay, I'm talking about twice a day. Okay, it blocks renin-angiotensin-aldosterone system, plus it increases BNP. Why? Inhibiting the neprilysin. Okay, you know BNP is a good thing, right? Then, so side effects. What will be the side effects of this? As we are inhibiting RAAS, there will be hypertension. As we are inhibiting RAAS, there will be hyperkalemia. So hyperkalemia can occur in all of these three, right? Also, there will be angioedema because of the angiotensin, your angiotensin receptor component. There will be angioedema because of the increase in the bradykinin. Okay, it's typical for the ACE inhibitor though, but yes, here also it can be seen. Okay, and so what are the contraindications? So if patient has started ACE inhibitor, just within 36 hours, and if the patient has already angioedema or pregnant female, okay, so as we know, ACE inhibitors, ARBs, ARNIs should be contraindicated or not be used in case of pregnancy. Okay, so this is the drug profile. Okay, so make sure you remember this. And for that, we have a Paradigm heart failure trial. So very, very important. So result we got, I think, in the early 2022. Then we have ACE inhibitors. Okay, sorry. Okay, sorry. Yeah. So then we have ACE inhibitors and ARBs. As you know, if we are not able to use ARNI, we can give ACE inhibitors. Earlier, it was the first drug of choice in mortality benefit patients of heart failure. So in our pramipil, we can use, and losartan is actually an ARB that can also be given. So dose is 2.5 mg BID. Okay, and here ramipil 2.5 mg OD, and we can give maximum up to 10 mg or 10 to 20 mg BID. Okay, but here make sure we do not use in the pregnancy, bilateral renal stenosis and angioedema, because ACE inhibitors can increase the bradykinin. Okay, so whenever there is an increase in the bradykinin, that can cause the cough. Chronic cough also can cause the angioedema. Okay, angioedema. Okay, that is basically angioedema means your allergic symptoms. Okay, then cough. In such cases, we have to taper ACE inhibitor. Cough syrup and all will not help. So we should taper the ACE inhibitors, and we should focus more on the angiotensin receptor blockers, like for example here losartan. Okay, losartan or your valsartan. Okay. So that has been studied. And then coming to the third drug in this. So as I said over here, RAAS inhibitor, then neprilysin inhibitor, then now sympathetic nervous system in the form of beta blocker. So let's see now beta blocker. Okay, so in beta blocker we have bisoprolol, cardioselective drug, 1.25 mg OD. Target you can give up to 10 mg OD also. Okay, that will reduce the heart rate, will reduce the symptoms of the heart failure. Also you can give metexcel or metoprolol succinate. The dose is 12.5 to 225 mg OD. Then carvedilol, cardioselective, 3.125 mg BID you can give. Okay, start only when patient is U-wall limit. This is very important. Okay, also why it has to be started only in case of patient is U-wall limit? Because we are affecting the contractility of the heart also somewhat. Okay, not more than that, but heart failure, but the heart rate. Okay, so for example, I'll just say that sympathetic nervous system, I said, was good in the early phase, good in early heart failure or acute heart failure. Right? It's because in early heart failure, because of the sympathetic nervous system, your ejection fraction is maintained because there is an increase in the adrenaline and all. Heart basically pumps stronger with the help of this. But if you give beta blocker, if patient is in the volume overload, that's in the acute heart failure, what will happen? This beneficiary effect of sympathetic nervous system will be inhibited. Okay, so there will be no good sympathetic nervous system effects. Therefore, we should use beta blockers only in case of chronic heart failure or the acute episodes of heart failure, or like acute episodes of heart failure has gone, okay, or passed. Then only you should use beta blocker. I hope I'm clear. Okay, so normally sympathetic nervous system has a beneficial effect in the early heart failure or acute decompensated heart failure. Okay, but if you give beta blocker, that's basically sympatholytic, right? Sympatholytic. That's basically reducing that beneficial effect, and that's why we should not give beta blocker in the acute phase or early phase. Should give it once the patient's volume status is like back in the normal state. That's why it's written over here. Only has to be given in euvolemic patient and not in hypervolemic patient. Okay, so it improves the ejection fraction, reduces arrhythmia, reduces mortality. It has been found in merit heart failure and Copernicus trial. Right. Then coming to the mineralocorticoid receptor antagonist. Okay, so MRAs. MRAs like spironolactone, eflornithine can be given, and they are both basically potassium sparing diuretic. Okay, they are basically potassium sparing diuretic. That means if patient is having hyperkalemia. Okay, so if patient is getting hypokalemia frequently because of the diuretic use. Okay, because of diuretic, then these drugs should be used. Okay, also have to show mortality benefit. Should not be used if eGFR is less than 30 and should not be used if potassium is very high. Because why? They are already potassium sparing. That means they're increasing the potassium. So what are those drugs? Spironolactone, 12.5 to 25 mg/OD. So you can, it basically you have to monitor potassium and creatinine in this question, because that can reduce the creatinine or GFR somewhat. Okay, therefore has to be used very, judiciously. The GFR is less than 30. Then eflornithine 25 by 50 mg/OD again acts with the same weight, but the spironolactone causes gynecomastia. Okay, as a side effect, gynecomastia. That means breasts are prominent or larger or bigger in case of men. Okay, in case of eflornithine, we don't do that side effect. That's why you can give eflornithine, and that's why you might have seen because of the diuretic. In case of chronic heart failure, diuretics are used, right? So diuretic can cause the hypokalemia. So because of that, you might have seen that diuretics are usually merged together with the mineralocorticoid receptor antagonist like your spironolactone. So the drugs, for example, aldactone, okay, then lacilactone, in which Lasix are present with your spironolactone, right? Even your Ditor plus, okay, in Ditor plus, the Lasix are with the spironolactone. Okay, Ditor plus, lacilactone. Also in case of Planet T. Planet T means eflornithine plus torsemide. Okay, torsemide. Okay, so these are some of the examples where the diuretic are combined together with the mineralocorticoid receptor antagonist like this. Now, the fifth drug here is SGLT2 inhibitor. It's a game changer for both HFrEF and the HFpEF. Okay, so what are the drugs we have? The empagliflozin 10 mg/OD and empagliflozin 10 mg/OD again same. Okay, so it reduces the heart failure hospitalization and also the death, and can be used both in diabetic, non-diabetic patients. Okay, so that's very, very important. So people used to think that SGLT2 is for the diabetic. So shall we give it in heart failure or not? But It's like irrespective of the diabetes status of the person, you should give empagliflozin to the patient, and that will show significant effect in the mortality of the person. Okay, so but make sure you have GFR more than 25 to 30 for the dapagliflozin and empagliflozin also. Okay, so also helps in the volume control, because I said you that it, in case of proximal tubule, it helps to excrete the sugars as well as water. Therefore, it can help in case of volume control also. So therefore, you usually, if you're starting these drugs for diabetes control, not for heart failure, then you ask the patient like more water also together, or proper hydration should be maintained. But if already patient is on the heart failure and you want to reduce the volume status of the patient, okay, patient is already hypervolumic, then HFrEF will any day help. And you don't need to tell patient like extra care of their hydration status. Okay. Then additional options, we have evaporating. Basically that acts on this sodium channel, okay, INA channel or funny current of the sodium channel, and that is basically used if the heart rate is even more than 70 irrespective of the beta blocker use. Okay, so that is typically given in the normal sinus rhythm patients. Okay, and also reduces the hospitalization. Then hydrolyzing nitrates have to shown some symptom benefits. Then loop diuretics, so it's given in the acute heart failure. As such, there are no mortality benefit, but it has shown mortality benefit in the acute heart failure because of the symptoms. So remember to start treatment, start low, titrate every 2 to 4 weeks. All these things what we just discussed right now, start with ARNI, SGLT2 inhibitors, okay, then LASIX plus MRIs should be given if patient is in the hypervolemia, okay, and beta blockers can be given if patient is not in the acute heart failure. Okay, so beta blocker can be given, and if ARNIs are not working, then ACE inhibitors or ARBs should be given. Not working in the sense, if their patient is sensitive, patient is having some issues with the ARNIs, then you can give ACE inhibitors or ARBs. So then, so this is your GDMT. That's what we just discussed. The first target is ARNI, beta blocker, MRA, SGLT2 inhibitor. That's again just to discuss the same thing. Add evaporating only if heart rate is more than 70, if sinus rhythm. Okay. Then avoid NSAIDs or CCBs in case of HFrEF, because that worsens the heart failure. Then loop diuretics, just for the volume control, there is no mortality benefit. Educate patients on daily weight monitoring. Okay, so if there is increase in the more than 2 kg weight of the person, that means patient is going into the heart hypervolemia. Okay, so daily ask the patient to check weight, and if there is increase in the weight of more than 2 kg in 3 days, then that should trigger the prompt action and starting the LASIX to the patient. Okay, so this is the summary. ARNI, sacubitril valsartan, referred over ACE inhibitors. ACE inhibitors, ARBs, enalapril losartan if ARNI is not available. Beta blocker like bisoprolol, carvedol, start for after diuresis, you should start this. MRA, when it's spironolactone, it should be avoided if hyperkalemia is there, because it's basically potassium sparing diuretic. And SGLT2 dapagliflozin can be given in both reduced rejection fraction as well as preservation fraction. And loop diuretic is usually given for the symptomatic relief in case of acute heart failure. Now, what is the role of digoxin? What is the role of diuretics? And when do we give the CRT, okay, cardiac resynchronization therapy, or we should we give implantable cardioverter defibrillator, ICD. Okay, so we will quickly see those stuff also. Yeah. So 68-year-old with HFrEF remains symptomatic despite optimal medical therapy. ECG shows LBBB with QRS of 160 milliseconds. So what should be the best option in this condition? So we should refer to the patient for the CRT, that is cardiac resynchronization therapy, because there is a risk of worsening heart failure in this case. So if the heart fails, then there should be something which maintain the normal ejection fraction. So that's your CRT device. Okay, and if patient is under the risk of arrhythmia, then you should give ICD, that is implantable cardioverter defibrillator. So let's see now treatment. So diuretic we discuss. We have loop diuretic like furosemide, torsemide, which basically acts on the loop of Henle. That's why the name loop diuretic. And furosemide, torsemide is given starting dose 20 to 80 mg of day. Torsemide is powerful, okay, almost 2 to 4 times powerful than the furosemide. So it's given as 10 to 40 mg OD. Okay, it has better oral bioavailability, and furosemide is actually available in the IV form also. So it's more preferred in case of pulmonary edema and the leg swellings. Then thiazide like we have metolazone. So they basically act like a thiazide diuretics. And here you have the doses as 2.5 to 5 mg OD, and it can be added if there is a looped resistance. Okay, irrespective of the furosemide, if volume status is not maintained, you can add thiazide. And finally, potassium sparing. If patient is getting the hypokalemic frequently, then you should add this panoretinol, which is a potassium sparing. Again, it has shown moderate benefit because of heart failure with result fraction. Okay. Side effects. So all but except this loop and thiazide have not shown any mortality benefit. So if they ask which diuretic has the mortality benefit, then that's your potassium sparing. Rest doesn't have much. Okay, then side effects, hypokalemia, we know that. Hyponatremia, we know that because we are already causing natriuresis. Okay, volume depletion can occur and ovaries can cause pre-renal AKI because of lots of fluid is not there, right? So therefore, there will be pre-renal AKI. Okay, so make sure you have to maintain the patient dry, but not dry enough to crash. Okay, that's very important. So then we can also give digoxin for rate control and symptoms. Access, there are no survival benefit of the digoxin also. And it has been more over given, like traditionally it was used a lot in patients of HFrEF. Okay, so doses 0.125 to 0.25 mg. Okay, per day, and that's lower in case of elderly or CKD patient. Target therapeutic ranges up to very, very important 0.5 to 0.9 nanogram per ml. Okay, mechanism of action is it acts on the sodium potassium inhibition, increases calcium, increases causality. Okay, so if patient has HFrEF, that means the ejection fraction, pumping failure is there. Therefore, digoxin will help very well. Okay, indication HFrEF with AF because it reduces the heart rate also. So we have to give HFrEF if patient is having artery fibrillation with the HFrEF. That artery fibrillation component will also be taken care because it reduces the contractility as well as reduces the heart. Okay, and if patient has persistent symptoms despite GDMT, you can add digoxin. Okay, but again, as I said, the therapeutic range is very narrow. So if it increases in the amount more than therapeutic range, patient will have toxic symptoms or the adverse symptoms of its toxicity. So what are those? So most common are GI, like nausea, vomiting. These are most common. But patient can have confusion, visual changes, yellow vision. Okay, even ECG like bradycardia, IV block, arrhythmias can occur. Okay, so we have to monitor potassium, renal function, and the digoxin level in this case. Finally, coming to the device therapy. So what is ICD and what is CRT? So ICD is implantable cardioverter defibrillator. That means if patient is getting into the ventricular fibrillation frequently or there is risk of cardiac arrest, then you should give ICD. So in which patient we need this? So if LVF is less than 35, NYHA is 2 to 3, okay, or patient is post-MI, okay, ejection fraction is less than 30, post-MI means there is increased risk of arrhythmia for primary prevention of sudden cardiac death. That's what we just discussed. Okay, so in these cases, we have to give ICD, that is implantable cardioverter defibrillator. This procedure is done by cardiologist or interventional cardiologists. Okay. Also remember here LVF, if it is less than 35 and patient is already on the 3 months of GDMT, that's guideline based medical therapy, still you are not seeing any benefit, then you have to do this. Okay. Then in case of post MI, ejection fraction after 40 days, if still the ejection fraction is not improved after MI, then you should consider the ICD. Okay. And similarly, if there is a non-reversible cardiomyopathy, then you should consider the ICD. Okay. Now let's see, when do we use CRT? CRT is nothing but biventricular pacing. It has to be given if AF is less than 35, NYHA 2 to 4, that means very severe. Okay. Then LBBB with QRS duration more than 150 milliseconds. These are the best basically responders. Okay. Then sinus rhythm. In these cases, it's necessary. Okay. So your CRT will improve the symptom, will improve the ejection fraction, and will reduce the mortality also. Okay. So combined device, that is CRT plus defibrillator, can also be used and ensure mortality benefit. Okay. So this is the heart failure staging based on the American Heart Association. A means risk factors are only present like hypertension, diabetes, obesity. B is structural heart disease is present like LVH, low ejection fraction post MI. C is structural heart disease plus symptoms are present. Like these are typical heart failure patients. And D is the refractory heart failure. That means patient is on the transplant or left ventricular assist device list. So LVAD is given for the patient who has ejection fraction very low and patient is symptomatic, not improving with the GDMT, not improving with the cardiac resynchronization therapy. So in this case, you might need heart transplant or the LVED, that is left ventricular assist device. Okay. Finally, coming to the NYHA functional classification, we know this. Class 1 is no limitation of activity. Class 2 is a mild limitation of the activity with ordinary activity. Okay. That means initially patient is able to, wash its clothes, perform daily regular activities, going to gym and all. He will feel no problem with that. But now with the ordinary activity also he is getting breathlessness. Then grade 3 is marked limitation with minimal exertion. That means I am just going to washroom and coming back and I'm having breathlessness. That will be my NYHA class 3. And class 4 is symptomatic at rest. That means I'm just sitting here at the bed, scrolling my phone and still I'm getting breathlessness. That's your class 4 of the heart failure. Okay, so very, very important classification. That's NYHA. And for breathlessness or dyspnea, in case of respiratory system, we use MMRC, that is Modified Medical Research Council classification for dyspnea. Okay, that is again 0, 1, 2, 3, 4, 5 classes. Okay, so summary table. Diuretics given for symptoms. Digoxin can be given for like the person who has atrial fibrillation with heart failure. ICD, we saw the indication to reduce the risk of sudden death. CRT to reverse the remodeling. And SGLT2, ARNI, beta blocker, MRA has the survival benefit. These are the 4 pillars of the therapy. So whenever you're managing the patient, ask about compliance and triggers. Like if patient has any infections, if patient is taking any medications like NSAIDs, anemia. Okay, daily weight monitoring we already discussed, should be asked to the patient. CRT helps to reverse LV modeling in wide QRS cases. Okay, in wide QRS cases more than 150 milliseconds. Then never stop beta blocker during decomposition unless there is a shock, and refer for transplant LVAD in case of stage 4 or class D of the heart failure. Okay, so that's all about the heart failure, guys. Okay, so we discuss HFrEF, HFpEF, when to manage, when not to manage, what medication should be given, how HFrEF, HFpEF are different, what are the risk factors for HFrEF, what are the risk factors for the HFrEF, echo finding we discuss. Then we discuss about the treatment, we discuss the importance of the BNP. Okay, we also learned about the mechanism, basic mechanism of heart failure. We also learned about how the pharmacology of the heart failure works. Okay, pathophysiology and everything we have covered. Then coming to the last section where we discuss about the treatment in detail. We talked about the different drugs, 4 pillars which are ARNI, beta blockers, SGLT2 inhibitors and ACEi inhibitors. Okay, then we talked about what other medication we can give, what to be given in case of AF with heart failure. So that's a nutshell discussion about the heart failure. I hope you understood. If you have any doubt, please message me or you can comment on this video. Thank you.